Okay. So just the roadmap, and this is a very general roadmap, but again, it's kind of nice to just see where we've been and where we're going with our material. So we've talked about history, we talked about use a little bit yesterday. We're going to continue talking about inhaled anesthetics today and then move into intravenous. What's kind of nice about the intravenous is that at the end of the chapter, it starts to really go through a laundry list of different types of intravenous anesthetics. And so I think from a pharmacology and from a pharmacist perspective, seeing the specific anesthetics that are used, how they're used, their effects on central nervous system function, as well as respiratory system function is important. And I think again, as future pharmacists, I think that's where probably your interest lies the most. And in some instances, we'll be discussing mechanism of action, but for a lot of them, it's still fairly uncharacterized or unknown. And we talked about that a little bit yesterday in terms of just overarching targets of anesthetics. For the most part, most of them have not been really well characterized, saying that this is a single ite or a single site or a single mechanism of action, but that's not necessarily the case for all. I see Keith's face. I was wondering if, do you have a comment?
Yeah, a little bit. I'm sure you've run over this already, but I'll just go ahead and pitch in on it a little anyway. Yep. The story of general anesthesia is one of the great stories of pharmacology. It might be the greatest story because until about 1850, there really weren't successful general anesthetics. There was a lot going on suggesting that it should work, but there were a lot of trials and things that didn't work out well, broken promises and things like that. But many people consider about 1850 there and the introduction of general anesthesia as sort of being the dawn of modern scientific pharmacology. So it's just a really fantastic story. And one of the, as you were just sort of hinting at there, Katie, one of the most amazing things about this history is that, you know, all the years, what are we at now, about 175 years later, something like that. If you look at the total literature and citations to various topics, general anesthetics has one of the greatest number of citations, if not the greatest number of citations out there. Yet despite that, there's still tremendous issues associated with the exact mechanisms of action. So tremendous effort still goes into trying to understand better how these remarkable agents work. And important to do that because, again, as I'm sure you already talked about, and you were talking about it there a little bit in the last few minutes, Katie, these remarkably wonderful agents are also tremendously dangerous. And so to understand what's going on there better and to develop anesthetics with profiles which are more acceptable from a risk-benefit analysis is certainly a goal of pharmacology. So with that, Katie, I'll stop. But I always like talking about the history of general anesthesia because it is so central to the development of modern pharmacology.
Yeah, Keith, and I would almost recommend open up the first lecture that I gave yesterday for no other reason than when I was talking about the history. There's a link at the bottom of that particular PowerPoint that sends you to a website that's entirely dedicated to the history of anesthesia. So it goes back to talk about opium, you know, and the use like, you know, hundreds of years ago or whatever, and it kind of goes through like the more modern anesthesia that we see now. So it's an entire online, I guess, historical website just dedicated to that. And so I know the image that you've shown in the past has been that picture of the physicians kind of in the arena, you know, yeah, observing kind of the first use of anesthesia. And I used that same image yesterday just because I think it's so amazing to think about how when these drugs were first being characterized, how novel they were and how revolutionary they were in terms of modern medicine. You think of surgical techniques and how hard it must have been to be able to conduct them prior to this and how this was really a game changer.
I'll take a look at that. It sounds exciting, Katie. Thank you.
Yeah, no problem. You might be the only one who clicks on it though. Okay, so I just wanted to, again, just review some of the big points that we went over yesterday that I think are worth revisiting. So things like the primary effects that a perfect anesthetic would have. So things that you want an anesthetic to have is to deliver unconsciousness. You want to have a certain amount of amnesia. You don't want necessarily somebody to remember the surgical procedure they're undergoing. analgesic or analgesia, meaning that there's a pain relief, inhibition of autonomic reflexes and skeletal muscle relaxation. You want, the patient to not necessarily be responding in any type of reflexatory way, and you also don't want the skeletal muscles to be activated either. So what's important to remember is, as we're talking about these different anesthetics, is that very few of them are able to achieve all 5 of these. So often they're using a combinatorial effect, and we'll talk about what that combinatorial kind of treatment strategy is called a little bit later. In addition to kind of these 5 primary effects and what we're looking for in anesthetic, just recognize you also want to have a quick on and a quick off effect, and we'll talk about that more extensively today too. And then also, like Keith was saying, is that these can be very dangerous substances, and so the wider the margin of safety, I think ultimately that's also going to increase I guess the way a anesthetic is kind of prioritized. If it has that wider margin of safety, it might be a little bit more relevant to be using for patients. Okay, so this again is a review from a slide we showed yesterday, but I just wanted to kind of reintroduce these idea of the inhaled anesthetics. So you have your volatile and your gaseous anesthetics. It's important just to kind of remember what the structures of these look like. And so in terms of characterizations, your volatile anesthetics, which we'll probably talk about a little bit more today, your halothane, your enoflurane, isoflurane, desoflurane, sevoflurane. We'll kind of compare and contrast some of the characteristics of those particular anesthetics. And then the gaseous anesthetics, things like nitrous oxide and xenon. Again, those are going to be already in the gaseous state. And then with the volatile anesthetics, those are going to require vaporizers. And again, there needs to be a tight level of precision there. Again, the margin of safety here might not be as tight as otherwise desired. So we left off yesterday talking about an application question referring to solubility. When we talk about solubility of these anesthetics, it's important to kind of look at a couple different factors, a couple different numbers. We looked at a graph that compared and contrasted the blood gas partition coefficient of the different anesthetics, of the inhaled anesthetics. So we were recognizing that halothane is the most soluble of these anesthetics. And so it's going to be that FA to F1 ratio also that's going to help be a predictor of the solubility. So here the FA that approaches the F1 fastest for the least soluble agents, and so you're seeing in this case nitric oxide being kind of on that fastest rate to 1, kind of revealing its lesser solubility. Again, this is just one way to look at the characteristics of these inhaled anesthetics. The table that we looked at yesterday is another great way, just because there's more information there. We looked at blood gas partition, but then I think there were some other characteristics in there that were really valuable. Okay, so as we're talking about inhaled anesthetics, just recognize that when these substances are being inhaled, there is going to be a changed heart rate. The increase in blood flow will lead to a shifting of the FA to FI rate, but also recognize that the respiratory rate is going to also, that heart rate is going to influence respiratory rate and the uptake of the anesthetic from the alveolar space. So there's definitely a close interaction with cardiac function and these inhaled anesthetics. Kind of continuing down, talking about some of the pharmacokinetics of this. In terms of the elimination of the anesthetics, this is going to occur when the anesthesiologist discontinues the use, or the alveolar concentration is going to fall very rapidly. That's going to occur when there is an increase in the rate of inspired air. So the ways in which elimination is going to differ from when the process of induction occurs is you're going to have this transfer of the anesthetic from lungs to blood, and this is going to occur via an increase of inspired air. Again, this is all going to be monitored by the anesthesiologist. The anesthetic gas tension may differ in different tissues, may vary, again, because you're kind of starting with tissues that don't have any of the anesthesia kind of in them. As the anesthesia gets inhaled, it's going to maybe be sitting in those tissues, and so as use is discontinued, some of that gas tension might still exist during that time. In terms of the pharmacodynamics, so we talked about MAC prior, kind of as a different acronym. In this context, MAC is going to stand for minimal alveolar concentration. And so this is going to be the concentration that is required to prevent any type of response that happens to any type of surgical incision or surgical procedure that has been that is being conducted. So this is a measure of concentration, obviously, and potency of that particular anesthetic. When we talk about CNS effects, not surprisingly, anesthetics are going to decrease the metabolic rate of the central nervous system, and that's going to be a function of its relationship with cerebral blood flow. So if we're looking at those MAC levels, again, MAC is going to be that concentration that either is going to cause some type of response to an incision. If you look below that, you'll see that cerebral blood flow is decreased. At that one level, you have unchanged cerebral blood flow, and then greater than that 1 point kind of concentration, you have an increase in blood flow. So when we look at some of these anesthetics, isoflurane, desoflurane, sevoflurane, halothurulane, and euflurane, you're going to see an initial increase in activity of the central nervous system, and then it's essentially going to decrease rapidly into a point of silence. And so when we're talking about central nervous activity for any of these anesthetics, just recognize that most often the type of measurement that we're looking at are EEG recordings. And so in some cases, that's going to be a direct measure of electrical activity. So if you see an electrical burst, that's going to be recorded here. But then in this case, you're going to see, again, an initial kind of rise in that electrical activity, and then it's going to decrease over time into almost a point of silence. It's, I guess, interesting to note that there are instances of clinical seizures seen with enflurane. And then another kind of interesting way in which these effects are kind of monitored is through Goodell signs. And so if you see here, you can see the different stages: analgesia, delirium, surgery, and then stage 4 is the respiratory paralysis, cardiac failure, and death, again, if it's proceeded to that point. But what's nice about this particular table is it shows you some of the changes that happen over these different stages in respiration, in eye activity, in pupillary reflex and dilation, as well as lid reflex, and swallowing and vomiting. So not surprisingly, as someone progresses through this stage, as a respiration is going to slightly increase up into the point of surgery. And then during delirium, you're going to have quite a bit of eye activity, still have pupillary reflex, not a ton of dilation, and then you'll still have lid reflex and some vomiting that can occur. Now during surgery itself, again, there's 4 stages within that. You can see the alterations in respiration during surgery, kind of that first part of this stage. You have a large amount of eye activity, the absence of the pupillary reflex, and then as you progress through that surgical stage, you can see there's an increase in pupillary dilation, but also a loss of lid reflex. So again, this is just one way in which the progression through the anesthetic effects are kind of characterized over time, and as the body kind of responds to those anesthetics in different ways. Okay, so I've done a little color coding on this slide, so if this doesn't make sense to you, please make sure that you speak up. But actually, I'll open up the chat just in case somebody has something to mention there. So the way I've put together this slide is that the red anesthetics that I've put here correlate to the cardiovascular effects that you see here. So things like halothane and enflurane are going to show signs of myocardial depression. Isoflurane and sevoflurane are essentially having minimal effects to cardiac output. So in terms of when we're making choices for anesthetics, if you remember, there are a lot of things to take into consideration. So the type of the patient, the type of surgery that they're undergoing, the age of the patient, are all important considerations to take into account. And so in this case, let's say if you have a heart patient that you're putting under, maybe an isoflurane sevoflurane is a better choice just because you're going to have minimal effects on cardiac output. And also later on, we'll talk about differences that different inhaled and IV anesthetics have on things like intracranial pressure. So if you have somebody who's dealing with like any type of, central nervous system issue, whether it be a stroke or some type of hemorrhage, that might also be something to take into account when you're making those choices. The respiratory effects of these different inhaled anesthetics. So halothane and sevoflurane are going to be agents for choice of individuals with respiratory issues, and isoflurane and desflurane. Their pungency makes them inappropriate for those patients because it causes bronchospasms, and so you don't necessarily want an individual who's already having issues breathing, having these bronchospasms as you're trying to administer this inhaled anesthetic. So this respiratory depression that we see here can be very great, and so it's important that ventilation is also co-administered with some of these inhaled anesthetics. Okay, I'm going to pause here for a question to see if anybody has any questions. I was told that even if no one asks questions, this is a good opportunity for everyone to kind of process. Again, I tend to be a very quick speaker, so I just want to pause for a second to see if anybody has any questions.
Hey, Katie, you said red equals cardiovascular effects. What does blue equal?
So, so I'm sorry, maybe I wasn't clear on that. So red is correlating, so halothane and inuflurane has display myocardial depression, and isoflurane and sevoflurane have that greater vasodilation. And so essentially I'm pairing the coloring with the, does that make sense?
Yeah, that makes sense now.
Okay. Okay, and I might even have to put a key at the bottom of this particular slide and maybe repost it so it doesn't cause too much confusion, because I was just trying to figure out how to have them correlate to one another and not make a mess of the slide. Okay, good question. Are there any other questions before I continue?
What do you mean by pungency?
So just kind of, I guess I can almost speak to isoflurane. It's almost like the smell to it is just so much that it takes your breath away, and so it can cause those bronchospasms just because the irritant sent to it. But I see Keith's face, so I feel like he might have something to add here.
I think you hit the right word there, Katie. Irritating.
Yeah.
I think the best way to think about it. Yeah.
Yeah, I mean, not like I've been huffing isoflurane, but I've definitely gotten a whiff of it before, and it just kind of takes your breath away, and it can be really irritating to your throat and your respiratory system. So I just think it kind of initiates that reaction of coughing. And so if you have somebody who already has those issues, don't want to exacerbate them at all.
Thank you.
No, thank you for asking questions. It just makes me happy. I'm like, the black holes of Zoom, people are listening. Okay, so continuing the discussion. So when we talk about there wanting to be like a wide margin of safety, but there is some toxicity that's related to the use of some of these anesthetics. So nephrotoxicity, so influrane and sevoflurane, they liberate fluoride ions, and this can cause renal injury. So these fluoride ions are released in both of these instances. And fluorine, there has been some evidence of toxicity after long exposure. So somebody who's been under that particular anesthetic for extended period of times has been shown to have renal failure. The sevoflurane, even though it works by a similar mechanism, there's really no evidence of change in renal function. So I don't necessarily know if it's a decrease in the amount of I guess, in which the fluoride ions are being released in that instance. For hematotoxicity, prolonged nitrous oxide exposure decreases methionine synthase, which could cause megaloblastic anemia. This is a concern for people who are consistently and chronically who are consistently exposed to nitric oxide. So the example that's given in the text is individuals who work in poorly ventilated dental suites. There could be a problem here with this megaloblastic anemia. An interesting kind of other type of toxicity that occurs is this malignant hypothermia. This is actually a heritable genetic disorder that occurs. There's a particular isoform of calcium ion channel that actually results in this particular response. And so it's this calcium channel that's located within the skeletal muscle. So somebody who does have this malignant hypothermia, if they're inhaling any of these halogenated anesthetics, they might have this type of response where you have this muscle rigidity, hypothermia, hyperthermia, rapid onset of tachycardia, hyperkalemia, and metabolic acidosis. And so again, I think it's hard sometimes for individuals to recognize if they are in fact, they have this genetic predisposition. And so once somebody does have this negative response, often it's often people advise them and their offspring to get genetic tested to see if they're carriers of this particular gene. The treatment can be treated via danitrolene, which is going to reduce the release of calcium. And again, the reason this occurs is because you've got this increase in release of skeletal calcium. I guess the other thing to note is there is some amount of hepatotoxicity that can also occur. And again, with halothane specifically, the rate of incidence of that is roughly between 1 in 20,000 to 35,000. So we talk about wanting to have that wide margin of safety. And in this instance, we can see that there are some cases in which toxicity does occur, whether it be through genetic predisposition, or sometimes it can be through the type of anesthetic that is chosen, or it could be due to exposure time as well. Hi, Keith.
Hi. I'll try to stop interrupting so much.
No, I think it's good, and I actually think it's like the best way to team teach.
If you think about these agents like halothane and so on, they're really relatives of substances like carbon tetrachloride and chloroform, which are really dramatic liver toxins. And indeed, in the history of anesthesia, agents like chloroform were at one time the prominent agents that were used. So they produced anesthesia, but they also lots of other problems. So, with the development of the more modern chlorofluorocarbons like halothane, you have a better ratio of what you want to have happen versus what you don't want to have happen. But nevertheless, they're all sort of relatives of each other. And so, unfortunately, that can sometimes produce problems with liver health. Thank you.
Yeah, no, I think, like I said, I think it's a great way to team teach because I think you've always got an awesome perspective. So we just talked about acute toxicity. In terms of chronic toxicity, people who are not necessarily undergoing, let's say, anesthesia for an individual procedure, but let's say individuals who work around anesthesias, things like operating room personnel. So that's how many of these studies were conducted. If you read in the chapter, they talk about how there is an increase in rate of fertility in individuals who work in operating rooms, the females who work in those operating rooms, but there hasn't been any hard and fast studies. Under normal conditions, they should be neither mutagenic or carcinogenic, but there has been shown an increased rate in abortion post-surgical procedures, but it's hard to kind of determine exactly what the reason for that is. Is it the treatment of the anesthetic? Is it the disease that the individual is being treated for? Is it a combination of those? Or is there maybe some type of stress that the body undergoes during surgery that could be causing that negative response? In terms of carcinogenicity, there has been some correlative studies that have shown an increase of carcinogenicity or cancers in operating room personnel, but there hasn't been any conclusive studies. Okay. So I'm gonna read this question that I just got via chat out loud. So what type of patients would need to be exposed to anesthesia long enough to start experiencing nephrotoxic effects? Is long-term in regards to a long surgery, or would it be longer than that? And I'm gonna say yes, when we're talking about these long-term effects, it would be, I think, surgical length that you're talking about, because I don't necessarily know if you could consider long-term like a combination or compacting all of the respective surgeries if somebody's undergoing several different ones. And so when we talk about nephrotoxic effects, yeah, I think when we talk about reported after long exposure, it would be the length of the surgery that we're talking about in that case. If your question is in regard to the enflurane.
Yeah, thank you.
Yeah, no problem. Okay. So I've been talking for a while. Let's apply this information that we've learned to a concept check really quick. So I'm going to go ahead and read it out loud because hopefully that'll help everyone. So a 35-year-old man is in the surgical holding area and being evaluated prior to a scheduled hernia repair. He asked the anesthesiologist about the type of anesthetic gas to be used because he recalls that his mother developed severe liver problems from a general anesthesia for a hysterectomy performed 2 years prior. The patient asks whether nitrous oxide might be used because he has heard it is a safe agent. To allay the patient's anxiety, the anesthesiologist proposes spinal anesthetic for the surgery. So the question, 2 questions I have for you is, what is the probable general anesthetic agent used for the patient's mother? And then second, what is the disadvantage of nitrous oxide as an inhalation anesthetic agent? So the second question, I don't think we've necessarily discussed today. We might have hit upon it yesterday. So this might require a little bit of Googling, but I'm just going to give you 3 to 5 minutes to kind of spend a little time looking at the possible answers for this question. Okay, so, make sure I'm unmuted. Okay, so I've got some answers that look good for the first part of the question. So just make sure you're also looking at the second question about nitrous oxide. Okay, so just in, okay, this makes me happy. I'm seeing more answers come in, which is awesome. I'm going to start going through the answer here just because, in the interest of time, because I want to try to see if we can get finished with the general anesthetics today. For the probable general anesthetic this used for this patient's mother, we talked about some of the effects that a halogenated agent such as halothane might have. And so the liver problems that she's experiencing would be directly related to probably the use of that particular anesthetic. And so the disadvantage for using nitrous oxide, again, it lacks anesthetic potency. So you're going to need a large amount of it in order to be able to essentially get to that MAC level. And it's associated with postoperative nausea and vomiting. So although nitrous oxide might be used in a combinatorial effect or with other anesthetics, and we'll talk about again that protocol later, using it as a single agent is probably not the best move forward. I see Keith again. Hi, Keith.
Just jump in real quick on that issue. You can't achieve total anesthesia with nitrous oxide. You can only reach about a 70% level unless you add some other agent in there. So, you know, it has a lot of advantages, but if you're looking for full anesthesia, you can't quite get there. Another little interesting anecdote about nitrous oxide is, I think you're probably familiar with it, is being described as laughing gas, because some people are sort of in that disinhibitory phase of exposure, laugh, but some people go the opposite direction and cry. So it can also be called crying gas. And of those who have sort of an emotional type of response to it it's about 2/3 laughers versus 1/3 criers. Anyway.
Oh, goodness. I'm sure that makes for some interesting dental offices.
That's right.
Kind of makes me think of Steve Martin in Little Shop of Horrors, a movie from the 80s, which is probably way before anyone in this class's time, but it shows some chronic nitrous oxide use and some of the negative side effects of that. Okay, so before we move on from this concept check question, I just want to make sure nobody has any questions about it. Somebody's actually seen that movie. What? Like it was a deep cut. Okay, so we're gonna kind of transition from our inhaled anesthetics to our intravenous anesthetics and start our discussion on that. So again, there are advantages of each and both, and we'll talk about how they're used kind of together. So the advantage to this is you can facilitate rapid induction. Here we can see some of the structures of common intravenous anesthetics, and we're going to discuss each one of these, I think, except for thiopental, that can be used as part of what's called the balanced anesthesia approach. And so I've been kind of alluding to the fact that there can be multiple different anesthetics used for a procedure. And so during this, you can combine some individual can combine inhaled anesthetics, sedative hypnotics, opioids, neuromuscular blocking drugs. And again, what this combination of drug approach allows you to do is kind of hit upon all 5 of those desired things that an anesthetic should be able to elicit. And so because no one anesthetic can kind of hit all 5 perfectly, by combining and using this balanced anesthesia approach, you can kind of hit upon all those 5 one way or another. I guess it's worth kind of recognizing these structures should hopefully show you that they're lipophilic, and not surprisingly, that's part of why their onset is so rapid, is because of that lipophilicity, and they're able to access the central nervous system so quickly. Once they've been administered, here's kind of the distribution into multiple tissues that you can see. Again, your percent of dose is going to be high in the blood. And then here you can see quite quickly, within just a matter of minutes, the redistribution to things like the blood and viscera. And then over time, within a few more minutes, lean tissue as well as fat. And so as that administration occurs, this drug is going to be finding its way into multiple tissues within the body, having those anesthetic effects. So probably the most common, most frequently used is going to be propofol. It's obviously used in many operating procedures, but can be used outside of the operating room. So the examples given in the text were things like in ER or interventional radiology. Because it is so lithophilic, it has to be made up in soybean oil, glycerol, as well as lecithin. This is an egg protein, so if if an individual has an allergy to eggs, that's something to take into account in the preparation of this particular drug. The working concentration of this is roughly 1% or 10 milligrams per mil, and in terms of molecular targets, this is going to be targeting that GABA A receptor. It is going to be rapidly metabolized by the liver, and post discontinuation of treatment, an individual generally wakes anywhere between 8 to 10 minutes. So it's, again, in terms of why you would want to use a balanced anesthesia treatment, this is a hypnotic but not an analgesic, and so you probably want to combine this with an analgesic. You still have twitching and spontaneous movements that occur. So there are some peripheral neuromuscular targeting drugs that probably would, again, be good in combination with this. But it does decrease intracranial and intraocular pressure and suppresses neural activity bursts. And again, that would be essentially observed via EEG. Cardiovascular effects decreases systemic blood pressure and is also respiratory depressant. And then in terms of how it's administered and its clinical use, you can see here essentially the range of how it's used, 1.5 to 2.5 milligrams per kilogram in IV and 2.5 to 3.5 milligrams per kilogram in kids. So you're going to have to increase the dosage for a child. Some anesthetic doses can be used to treat post-operative nausea and vomiting. So it has uses outside of just in the operating room, as we mentioned at the beginning of this slide. Hi, Keith.
Historical note, Michael Jackson, that's what killed him. The problem is they were using it as a sedative hypnotic agent, which it is, but it's got to be done under close supervision. And as you can see from the characteristics that are described here, it's not the sort of thing you want to mess around with in sort of a casual manner. And unfortunately, it was fatal for him. For those of you who have experienced propofol before, and that may be many people these days, because it is probably the most common inducing agent for anesthesia these days, it has incredible amnesic properties, just an absolutely huge efficacy for amnesia.
And there is, I guess, to note here, another kind of not side effect per se, but there can be some pain in the administration of propofol. And so that kind of leads us to like the next drug that we'll talk about here, which is phosphopropofol, which is a more water soluble. It's actually a prodrug for propofol. And so because of that, less pain is essentially observed during this. It's sterile, aqueous, colorless, clear, and applied at 35 milligrams per kilogram. And the more common name is Lucidra. The pharmacokinetics, because it is a prodrug for propofol, it has very similar pharmacokinetics, but its onset and offset are going to be slightly slower just because it has that prodrug status. And again, because it is that prodrug for propofol, it has a lot of the same characteristics and is used very similarly for its clinical uses. Does require supplemental oxygen. And in terms of dosage, the initial bolus is 6.5 milligrams per kilograms, and your supplemental doses are 1.6 milligrams per kilograms. Just recognize that these numbers have to be altered for various reasons. One of them might be age of the patient, and the other also might be weight constraints. So if a patient is below the 60 kilograms or above the 90 kilograms kind of range in which these dosages have been calculated for, you're going to have to kind of alter the dosage accordingly. Okay. Barbiturates. So the barbiturates, again, that's kind of an entire umbrella of category of drugs, but the barbiturates we're specifically speaking about here are thiopental and methotrexate. And there's essentially going to be what we'll be discussing here. They're going to activate the GABA-A receptor, very similar mechanism of action that we saw in propofol. They do have hepatic metabolism. Methotrexate has a shorter elimination than thiopental, but thiopental has a larger plasma clearance, and so that kind of balances those two components of the pharmacokinetic profiles of these two drugs. If administered through repeated bolus injections, recovery would be prolonged as compared to propofol. And so essentially when we talk about barbiturates, the effect that they have is going to be dose dependent on the amount of barbiturates that you get. So at lower ends, you could just have sedation. At higher ends, it's going to have the general anesthesia effects that you are, for the purposes of this discussion, that we're trying to achieve. And ultimately, similar, not surprisingly, that correlates to the EEG recording. So under those lower doses, you're going to see some minimal activity that's still occurring. And then at those higher doses, you're going to see kind of a more silenced electrical brain for what we're describing here. Not surprisingly, it acts as a respiratory depressant. In terms of kind of clinical uses and dosage, thiopental is 3.5 milligrams per kilograms in IV, and methotrexate is 1 to 1.5 milligrams per kilogram. And I'm not necessarily going to ask you specific dosages on the exam. I think one of the reasons that I like to just include these on the slide is just to kind of give you a relative understanding of how different the drug dosages might be relative to each other. So I don't necessarily need you to memorize specific numbers for these dosages per se. But I guess it's a good time to kind of pause for a second if anyone has any questions. And also keep my eye. Oh my goodness, okay. So we have just a few more slides, but I do recognize that we are at 1:49. So I guess I'm just going to pause here since we've essentially run out of time. What's nice though is we're getting very close to kind of catching up and hopefully getting back on track in terms of the schedule that has been set before us. I've got 3 or 4 more slides of general anesthetics that we can discuss on Tuesday, and then I'll start our discussion of local anesthetics that day, I think, which will be kind of nice and interesting compare and contrast between the general anesthetics that we're finishing up here. But again, I'm talking still. Does anybody have any questions or concerns at this time about the material, about course execution, about anything at all? No? I'll take the silence as a good sign. It's always just, I always feel like something's wrong when I don't hear anything. But okay, well, I guess if that's the case, I'll let everyone go. Have a wonderful weekend. Please make sure you get outside and enjoy the sunshine. Thank you so much for your time and attention today. And like I said, if you have any questions about anything, feel free to reach out over the weekend and I'd be happy to answer them. I will be getting a review sheet out or a study guide out probably tomorrow over the material that we've covered. And hopefully that should be a useful supplement for the exam coming up next week. And I see Keith, so I want to make sure whatever announcements he has, he's able to get in as well.
I'm good.
You're good?
Yeah.
Okay, wonderful. Well, thank you all for your attention. Have a great day.
Take care, everyone.